Yeah, I do have a second chocolate fish for you if you really want one. Yeah. Tēnā koutou katoa, ko manaia te maunga, ko ruaka te awa, ko Ngāti Pākehā te iwi, ko Kyle Eggleton taka ingoa. So, as you've heard, I'm a rural GP. I work up in the north, and also I'm a part-time lecturer at the University of Auckland. But my rural roots really stem from my early childhood. I was brought up in a small village called Waimar, which is in the South Hokianga, and I think you can probably guess which one I am there in that photo. We're the only Pākehā family in that community. My mum was the school teacher, she's the one sitting down, and Nana Maud was the person standing behind my mum. She taught me haka and waiata, along with all the other kids, and te reo Māori. Not that my te reo Māori is very good these days, but I try. I can recall my father speeding along the dusty gravel roads of Waimar in his red Mazda RX-3, past those blue peeling houses that you see up in the Hokianga. And my sister and I were unsecured in the back seat, sliding around those gravel roads. I always had the constant taste of bile in my throat that threatened to explode out. And I remember my mum feeding me raisins on our weekly trip to church. And I think that's why I'm allergic to raisins this day, with the associated vomit, and why I'm probably allergic to church as well. The big town in those days was Kaikohe, and Kaikohe back in the 1970s is a bit of a, kind of like was a big metropolis to my little eyes. It's now a bit of a pale imitation to what it was back then. It took about 40 minutes one vomit to get to Kaikohe from Waimar. The butcher used to feed me up with lunch and sausage for the trip and the vomit back home. Medicine in those days was truly rural and remote, and the doctors were and still are based in Rawene, and I know there's a few Rawene doctors here and some students from Rawene as well. Tony Birch was the doctor when I was a kid there. My mum and dad used to talk about how they used to go to Tony's place, and he used to ply them with all this fancy alcohol from France. It was back in the 1970s, you couldn't get wine, but that was my mum and dad's recollection of Tony. But Tony was also involved in doing kind of some surgery. So he did appendectomies, and Paul Bowker, who's another recently retired rural GP, did the anaesthetic. Tony was also involved in obstetrics, and he delivered my sister Briley. Hokianga Health was renowned for its involvement in obstetrics. And in the 1940s, the indomitable Dr. George Smith, who's seen in that photo there, provided a service called the painless childbirth, in which he'd give women Nimbutal, which is a barbiturate. And they would go to sleep and they'd wake up with this baby in their arms and no recollection of having given birth. Women from all over the north would flock to Rawene for the painless childbirth. And that included my wife's grandmother, who went to Rawene to deliver my father-in-law. So he had a barbiturate birth, and that probably explains some things about my father-in-law. But what Dr. Smith was most famous for was setting up of the Hokianga Special Medical Area. And health in New Zealand, including hospital services, up until about the 1930s, was fee-for-service. That meant you paid when you went to hospital, and of course you paid when you went to see the GP. The Labour government at the time wanted to introduce a free healthcare system, but the British Medical Association at the time persuaded GPs and the Labour government that it wouldn't involve general practice. And so the world's first universal healthcare system, free healthcare system, didn't involve general practice. The cost barrier to accessing healthcare was something that was recognised by Dr. Smith and motivated him, and he spent some time advocating for setting up free primary healthcare services. And eventually the government introduced the concept of special medical areas. These were medical areas which were predominantly in rural and remote and predominantly Māori communities. And there were 34 of these special medical areas which were established. And many of these thrived, and they developed special relationships with the communities that they served. And this relationship with communities is the first thing that I'm going to talk about when we're trying to talk about strategies to reduce inequity. So my talk really is about how we as rural GPs and nurses can reduce inequity. And there's many things we can do at a political level, but there's some things we can do as individuals, and our engagement with the communities is one of the very first things we can do. The founding document of primary health care is called the Alma Ata Declaration. Now, many people get the idea of primary healthcare and primary care conflated. There's a distinct difference between primary care and primary healthcare. Primary healthcare is the involvement of communities. It's about empowering communities and empowering individuals. And it's a philosophical difference between primary healthcare and primary care. Primary care is what we do as doctors and nurses. Primary healthcare is a completely different thing. And the Alma Ata Declaration was really driven by developing countries at the time who wanted to have a accessible, free or cheap service to access healthcare. So key amongst these proposals in the Alma Ata Declaration was community participation in healthcare. Now, I do have a chocolate fish, and this chocolate fish is for anyone who can tell me where Alma Ata is. What is the capital? What capital is Alma Ata, a country? No. No. Sorry? Close. It's a stan. Kazakhstan. So it comes from Kazakhstan. It used to be in those days it was USSR. So there's a gradient of community participation. At the very bottom level is consultation, and consultation is kind of things like feedback forms. Now, I don't know about you GPs out in the audience, but I don't find feedback forms particularly useful. I know that the college does them, and 95% of the time they say how wonderful I am. The rest of the time they say, I waited too long to see you, or my hair needs a cut, or something like that. So these kind of this feedback form that very, very rarely lead to any substantive changes or reductions in inequity. But as rural practitioners, we are embedded in communities, and that makes it so much easier for us to implement the second tier of community participation, which is known as participation as a means. So some examples of participation of a means includes community meetings, education sessions. I know Chris Reed, he told me he's been doing some community meetings with his practice. So one of the ways in our practice that we've tried to implement participation as a means is to hold regular community hui in the small towns that we service. Just for some contextual background, you heard that I work for an iwi health provider, so I work for Kia ora Ngātiwai. Ngātiwai is the iwi that runs from Rāwhiti, Cape Brett, all the way down the coastal strip of Northland, down past Ruakaka and Waipu, down to Snell's Beach and across to Aotea, which is a Great Barrier, although our service area really is only the northernmost part of that. And we do small outreach clinics in about 3 days a week in small, very isolated towns. At one hui, we had a number of people talked about how they saw a lot of people who are new to the service coming into the community, or the whare that we're in, and they looked a bit lost and kind of got a bit lost in the system, and they proposed that they would set up a system of aunties who would welcome everyone that came into the waiting room. So here's some of the aunties that look after our waiting room. So we don't have receptionists, it's the aunties that run the show. And they do things like they set up a volunteer roster, they get there to the whare very early, and they set up the clinic for our nurses, and they kind of register everyone that comes in, and they make sure that people are seen in a timely manner. And then they start doing things like, they start worrying about people in the community that weren't being looked after, and they'd drag them in and make sure they got seen. And then I started finding out, well, I could actually use these aunties in a slightly different way as well. I had one whānau who had, the child had a cleft palate and needed cleft palate surgery, and they were rather transient, and they kind of got lost to the system. The hospital couldn't track them down. The hospital were concerned and thought that they were naughty, so they made a notification of concern to Child, Youth and Family. And when I found out, I just contacted the aunties, and within 20 minutes, the aunties had tracked down this whānau, and we'd linked them up to the surgery. So that's the power of what you can do when you have the community that's involved in healthcare. So this form of community participation, which the patients' voices have been enabled, has resulted in increased acceptability of our service. And when we hold hui, the people talk about how they really like coming along because they feel like they've been welcomed and they're part of the family, and it's a wider whānau that they're part of. And acceptability is one of the concepts, or wider concepts, of access. So those of you who have read about access know that we talk about acceptability, we talk about affordability, we talk about accessibility, which is your geographical kind of location of your clinics, availability and accommodation. And all these things we need to address as doctors and nurses in order to address inequity. We need to kind of address each of these barriers. And there's a body of research that does demonstrate that increasing community participation in healthcare will result in improved health outcomes and a reduction in inequity. So the next level of community participation is known as substantive participation. And substantive participation is when a community group is actively involved in setting priorities and implementing programs. An example for our organisation is a weight loss program that we ran a couple of years ago. We had a group of Māori women who approached us and said, we'd really like help in losing weight, but what can we do? So we set up a small steering group and eventually got some funding together from a grant that we applied for, and we set up a Kaupapa Māori weight loss program. We called it Kaupapa Māori exercise program. We didn't want to really emphasise the weight loss. We called it whakapākari tinana, which means strengthening bodies. And one of the key elements of the program was that it was really community run. So here's a little clip of our gym program that we ran. It was based on Muay Thai, so it was kind of eccentric exercises. And that wasn't really the key thing. The key thing was that it was based on kaupapa Māori principles. So whakawhanangatanga was one of the key principles in which people made connections with each other. If you keep on watching this clip, it goes round and round, you'll get dizzy. So we had whole whānau come along to this exercise program, and they would they had grandparents and their mokos and parents, and the parents would do the program while the grandparents looked after their mokos, and then the kids would do the kids program, and it truly was amazing. We enrolled 96 participants, and here's our results from the weight loss. So the average weight loss was 5 kilograms of weight loss per 100 days. So after 200 days, the average weight loss was 10 kilograms. Not only did we notice that people's weight decreased, but their mental well-being improved as well, because we actually measured their mental well-being, and their mental well-being substantially increased. We also noticed that people's blood pressure decreased as well. And we just published this paper in the Journal of Primary Healthcare last week, if anyone's interested in having a look at it. But, you know, what I think really was the important thing in this program was that, as I said, the vision came from the community, and they were totally involved in it, and they really took it over. And they set up a Facebook group, and they encouraged each other to continue to attend, so we had good attendance rates. The other thing they did was when they saw each other in the supermarket, they'd say things like, "Hey, you, I don't think you should be eating that." So the final rung of community participation is structural participation. And in structural participation, communities have active governance roles. And what that means is that the community is actively governing the healthcare. And I acknowledge that's going to be very difficult for many of you who are working in private rural practice. But this model is implemented successfully by a number of rural practices, and I want to take you back to the exemplar of Hokianga Health and my organisation as examples of rural practices that have community members which are governing them. In my organisation, the entire board is made up of community members, and this creates a sense of ownership in which patients, rather than seeing equity issues as being something they have no control over, they know that they can go and talk to auntie or uncle who's on the board and get things addressed. So that creates change. And what both organisations have done as a result of community governance is to deliver their healthcare in outreach clinics. And this negates or reduces some of the issues of transport barriers all rural patients face. One of the consequences of small rural outreach clinics is they become more than just a clinic, but they become a community in itself. And Robin Kearns, who's a professor of geography at University of Auckland and who was my supervisor for my Master of Public Health degree, which I did in geography and public health, undertook a body of research in the Hokianga. And what he did was he sat in these small rural clinics observing people. I don't know how he got ethics for that, because he was a very tall Pākehā guy sitting in the waiting room of these small clinics, which were predominantly Māori, and he was sitting there with his newspaper, making notes on what people were talking about. But what he found was that patients enacted a form of healthcare that we all take for granted, and that is that patients started caring for each other, and that's one of the things that we can try and reach in our community clinics. So the major themes that Robin uncovered were that patients would talk about community concerns, they'd give each other health tips, they'd inquire after family, they'd discuss employment opportunities and education issues. And in my organisation, the outreach clinics are located in schools and in community centres and rural first aid posts, and entire whānau would come along and they would support one another and they would chat to each other in the little waiting rooms that we'd have. And I have 40 people turning up in my waiting room, but I only see 20. The rest are just there to have a bit of a chat. When I say, do you want to come and see me? They say, oh no, I don't want to see you. People would bring in second-hand clothes, and there's a bit of a fight over the second-hand clothes in our clinic sometimes, and spare veggies, and cousins would catch up with each other, and people would ensure that elderly aunts and uncles were seen first. So this example of community governance leading to substantive changes in delivery of healthcare leads me to the second point about reducing inequity, and that's about the role of practice and practice culture. So I don't know whether many of you reflected on practice culture and what it's like. The various government initiatives have tried to push us into developing integrated family health centres, and patient portals, and more recently neighbourhood healthcare homes. And all of these have at least one aim of trying to reduce inequity. And I've always been quite intrigued by government and DHB initiatives and the lack of evidence behind them. However, addressing inequity, yes, is always tacked on like a buzzword with nothing really substantial behind it. Fancy new buildings with a large number of healthcare providers does not in itself reduce inequity. For example, in another one of Robin Kearns's papers, he contrasted modern urban accident medical centres with rural community-owned practice. In the former setting, patients commented on the material aspects of the practice, and in the latter, patients commented on the relational aspects of the practice. So inequity is not solved with a colour-coordinated daycare and a nice practice logo. In the neighbourhood healthcare home model that we've imported from the premier example of primary care in the world, the United States, there's very little evidence that a number of the elements of the neighbourhood healthcare home will reduce inequity. For example, lean thinking, which encourages practice efficiencies, does not increase patient satisfaction. Telephone triage in 2 studies published this year demonstrated it does not improve universal access. Rather, it was more likely to increase GP workload. And patient portals have very limited evidence that they reduce inequity. In fact, there's more concern that they may increase inequity due to differential patient engagement and recruitment. So I think we have to be very careful with how we introduce technological innovations and think about the reasons behind them and how we go about implementing them. We seem to be in virtual awe of technological innovations and believe that healthcare problems can be solved by running around with an iPad, treating skin sores and swabbing sore throats. This does not address inequity. It's simply swapping an access barrier with a transactional form of medicine that will have unintended consequences. And chief amongst these is the loss of an opportunity to build meaningful relationships with people that truly reduces inequity. A participant of mine in a study that I did drew his idealised waiting room. So the central circle in this picture represents a patient portal, where he initially thought he could book an appointment and get some minor healthcare complaints sorted out. And when I questioned him on this, he remarked that the circle also represents the eye of the receptionist. He called it the evil eye, who he thought was judging him. And his reason for having a portal was that he could avoid discrimination by the receptionist and he could avoid talking to her. And I've always thought there's more simple things that we could do to improve access and equity. And one of these things is changing the culture of the practice. And this starts with the first person that the patient sees. And that's the receptionist, who's also known as the dragon at the desk. So that latter picture came from a study that I did to determine how marginalised patients view receptionists. And I got them to draw some of their ideas. I'm going to share some of their pictures with you. So this is a picture of a person who said that being in the waiting room was like being in the lift. He was like waiting for your number to be counted. And he felt that everyone else in the waiting room was just looking at him because he was a little bit different, being Māori and having dreadlocks. I didn't draw, the dreadlocks aren't in this picture, but that was his idea of what the waiting room was like for him. This picture's by someone who drew the receptionist, and she said she's just busy with her busyness. And then she kind of looked at that picture and reflected that she'd like the receptionist to be more mobile and more visible to her, so she then drew in the legs underneath it. And this picture is by someone, she's the person in turmoil, that rectangle on the one side with all the squiggly lines, and the waiting room is the grids on the other side. And she said that being in the waiting room was like being in jail. She had anxiety and she needed to get out frequently, but she felt that she couldn't because she was waiting to get called up. Another participant drew this picture, and for her, this is her idealised waiting room. She wanted the waiting room, or the practice, to be enveloping and enfolding her. So she's the Golden Globes walking into this enveloping, welcoming practice. And the receptionists are that calm blue pool in the centre who are wrapping themselves around her and looking after her. And she said that if the practice was like this, she would also be those Golden Globes going out, not only in but out. And as she went out, she'd be imparting healthcare and goodwill to everyone else in the community. So what the general theme of this study was that patients wanted to belong to a practice that genuinely cared for them and looked out for their interests. In some ways of achieving this, including look at who you hire for staff, I think ideally our practices should represent the communities that we are in, so that patients can more easily identify with us. The other thing is reorientating our receptionists away from protecting us to protecting patients. And I always tell my receptionists, you're not here to look after me, you're here to look after the patients and to advocate on behalf of them. So the third strategy that I want to talk about in reducing inequity is about the person, and that's about our interactions between ourselves and patients. And this, I think, is one of the more critical aspects of reducing inequity. And it's the simplest thing to do that we can all do as rural practitioners, but we perhaps don't consciously do it enough. And that is to form meaningful relationships with people in front of us. Sometimes we're so busy we forget to take the time to connect with our patients. And for patients who have had a bad experience with the healthcare system, or are scared or apprehensive, then making connections can overcome some of these things. And one of the strategies we teach at the University of Auckland is called the Hui process. So the Hui process consists of 4 steps that can assist students in structure and consultation. The first step is the mihi, and the mihi is your introduction. This is where you introduce yourself and your role and make sure you pronounce the person's name correctly and they understand what's going to be going on. The second step is the whakawhanangatanga. So the whakawhanangatanga is the process of making relationships and connections with people. Some months ago I had a patient who came to see me for the first time, and during my process of whakawhanangatanga with her, I discovered she'd grown up in Waimā. And I said, well, I come from Waimā too. And she looked at me rather quizzically, because I was on the rather pale side. And she said, I remember you. You were the little white boy whose nappies I used to change. And that's her there. Now, while the process of whakawhanangatanga doesn't normally lead to the discussion of the doctor's naked body parts, it can make us naked in another sense, and that is that patients can see past our veneer as doctors and relate to some aspect of ourselves as a person. Being vulnerable is not a bad thing. Many years ago, when I was a hospital registrar, my wife and I ended up on a nudist beach. Now, I thought when in Rome, do as the Romans do. So there I was, looking like a starfish, when all of a sudden I heard, hello, Kyle, and over comes a nurse from work, who was also like the Romans. I can't remember much of the conversation that followed, except that it involved a lot of crossing of legs and an invitation to play nude petanque. Many years later, I was working as a GP, and this person enrolled as a patient with me as she felt comfortable in having full body skin checks performed. The point of this rather revealing insight in myself is that by revealing parts of ourselves to patients, we're better able to make connections to patients. But obviously, what we should reveal should be within safe limits. So the third step in the hui process is setting the kaupapa, and this means attending to the purpose of the consultation, and should encompass patient expectations and values. A couple of years ago, the PHOs that I belong to shifted resources into CVD screening, and all health practitioners were encouraged to screen everyone that came in through the door that was eligible. And in one particular PHO, what happened was that the CVD risk assessment rates really increased dramatically, but there was an unintended consequence. And that was there was a shift in resources away from patient-led matters, as well as a loss of focus on other aspects of inequity. An example of this was that cervical screening rates for Māori women decreased. And as I reflected on this quite a lot, and I wrote a poem on it, which I'm going to share with you. And this poem is called Heart Risk 1, Sore Puku 0. Everyone over 20% heart risk needs pills, or that is what the experts told me. A little heart-shaped one to thin out your blood, a little white one to drop your pressure, and a little oval one to clean out your tubes is what I told my patient. But I only have a sore puku, is what my patient told me. You're doing a good job by talking about pills. Well, that's what the experts told me. Your heart might explode, so keep taking the pills, is what I told my patient. But the little heart one makes me bruise, and the little white one makes me dizzy, and the little oval one makes me ache, is what my patient told me. Don't forget to check for diabetes, ask about smoking, and offer a flu jab, is what the experts told me. Sugar's eating your veins and smoke is blocking them up, and the flu might kill you, is what I told my patient. But I really came in about my sore puku, is what my patient told me. Your numbers aren't great, you need to do more smears, is what the experts told me. I know that you're a man, but have you considered a smear, is what I told my patient. I don't think I want to see you again. You haven't asked about my sore puku, is what my patient told me. The final step in the hui process is called the purapuraaki, and the purapuraaki acts as the concluding rituals of a hui. However, in this context, the purapuraaki acts to ensure that patients have understood the outcomes of the consultation and know what happens next. Last year, my daughter broke her ankle. She was 15 at the time, and we had this arduous journey through the public health system. And one thing that stood out for me was when the orthopaedic registrar came up and was talking to my daughter and said, you have a Weber B fracture. What we're going to do is insert a syndesmosis screw because the syndesmosis is probably disrupted. You could get some complications such as non-union. You have any questions? No? So, although we can put in place a number of changes that can address inequity, there's one final element, and that's ourselves. And in order to unpack this a little bit more, I want to take you back to the start and talk about my own background and reflection. I am a seventh generation Northlander. My ancestors immigrated to Northland in the 1850s from Nova Scotia. They settled around the harbour of Whangarei and Hikarangi, Kaihau and Kerikeri, and they lent their names to bays and beaches and roads. McLeod's Bay, Scudder's Beach and Donaldson Roam all represent the renaming and reshaping of the environment by my ancestors. And in talking about equity, I've come to realise that my own background and historical connections have contributed in some way to the reshaping of cultural norms. And this little picture kind of like represents how we view the world sometimes differently to other people. When I was a kid growing up in Waimā, the kids used to say, we're going up to Auckland. And I'd say, no, you're going down to Auckland. And when I was living in the King Country as a kid, later on, the kids would say, we're going down to Auckland. And I'd say, no, you're going up to Auckland. It's very difficult for us to realise that our values and ways of thinking are not the only valid ways of thinking. Paparangi Reid talks about worldviews as being like a valley surrounded by a mountain. And the appearance of the valley really differs depending on which mountaintop we stand on. In order to understand that our patients might have a different way of looking at a problem, we need to be brave enough to realise that they might be standing on a different mountain to us. The way in which we think is shaped by numerous experiences, and our decisions and our actions are often unconscious as our brains quickly assimilate patterns and make decisions. And when these unconscious thoughts result in us making decisions that are unjust, then this is termed unconscious bias. In order to understand this a little bit more, I'll tell you the story of my own racism. So I was a young GP, and like the good and enthusiastic GP that I was, I decided that I'd do an audit on statin prescribing for patients with established cardiovascular disease. Now, I said I'm not racist, so I thought my hypothesis was that my rates of statin prescribing would be the same between Māori and non-Māori. And what I found was that my rates of prescribing statins were lower for Māori than they were for non-Māori, and this really threw me. And it created some dissonance within me. And I spent some time reflecting on this and kind of really thinking about what this meant. So I started to challenge my assumptions and was often left surprised by the outcomes. For example, I had an elderly Māori patient with angina, and when I suggested in positive fashion that statins might reduce mortality, she said, "Well, I don't want to die and leave my mockles behind." And challenging our unconscious bias is an ongoing and constant process. Just the other day, I had a patient who needed surgery and was going to be waiting for a long time on the public waiting list, and I was explaining this to him. And he said, "Well, what happens if I have medical insurance?" And I really hadn't thought to ask about medical insurance. It didn't really cross my mind. It wasn't a likelihood, and that was really kind of reflecting my unconscious bias that I have. So there's numerous strategies that I've talked about in this talk about how we can reduce inequity. And I've highlighted 4 that I think we can all use as rural practitioners, and that's about being more embedded in our communities and empowering our communities, about looking at how our practice culture is and how we can modify our practice culture, how we relate to other people and our interactions with them, and finally, how we look at ourselves and kind of realise that we all have unconscious bias and we need to address those. I think if we do these things, I think as rural GPs, we're more likely to be able to do these things because we're actually embedded in our communities, aren't we? And we can enact many of these things that our urban colleagues can't. We're more likely to have a well-defined community and be part of that community. And I think as a result, we're able to establish connections with people a little bit better and allow our practices to become an outreach of communities. So addressing inequity is something that we can all do, and it's not just all right to say that it sits outside our control. So thank you.
We have time for questions.
Is that going to work? Oh, that is going to work. It's Steve Main. I'm a newbie to Hokianga, and you are really from Hokianga. You've actually just opened my eyes. Thank you for that brilliant talk, Kyle. In terms of subconscious bias, when I first met you, you were just another guy. Then you had the policeman's hat on, and you came to tell us about how we had to do this better and that better and the other thing better. And
I'm sorry about that.
Yeah, okay, don't worry about it. It was related to the sore throat program, and we crossed swords slightly on that. And now I see that you're virtually poacher turned gamekeeper, and I commend you for that. Thank you very much for that talk. That's absolutely brilliant. And the subconscious bias is so easy to ignore. And you've used the exemplar of Hokianga Health as it's held it up as a model, and I absolutely agree with you. I mean, I very much think that Hokianga Health and the special medical area and the free service is a superb model, and it's the way we should go. However, we have some of the relatively worst HbA1c rates in the north. We have got problems with cervical smear uptake. We have got difficulties with flu vaccines in general. We've got a whole bunch of people who don't like having their kids immunised. I don't know. I've never wondered whether that was important or not. And I would have to ask all of my patients and colleagues, whatever their colour and their race, exactly whether they thought it mattered more how you live, how long you live. But thank you for that talk, and that's brilliant. It's made my day. Thank you.
Thanks, Steve. I thought you'd be here, so I just put in the
Well, absolutely right. Yes.
Hi, Kyle. Chris Reid from Kerry. So my question is going to be around the community, and how far do you think we truly have to go with respect to inequity? And I'll just highlight my patient forums that we do at Kerry Medical Centre. We've had 3 now. The first 2 were in the local theatre, and 200 patients turned up to each one. Fantastic success, of which about 3 were Maori, which was not representative of our population. So the third one we had the other week was at the local marae, after much talk to the Kumatua, and it was advertised in the same way, everybody welcome, and not one Pakeha turned up. Just highlighted, I was quite deflated, and so my question is, how far do you think we truly have to go?
Yeah, that's a difficult question. I mean, I think for me it's easy because my community is a rather homogenous community. It's predominantly Māori, and so our community consultations are held in a particular way, which is hui and the processes of a hui. I think whatever, like holding the first thing that you did was, you had predominantly Pākehā patients turning up. Well, I guess would be expected with the kind of like the location that you had. I don't know. I don't have an answer for you there, Chris. But I think that we do have to extend ourselves and we have to challenge ourselves a little bit more. And I think, yeah, I don't know. Not a good answer.
I'd just like to say thank you very much, Kyle. That was fantastic. My comment, rather than any question, is this is not a model of healthcare for rural communities. This is a model of healthcare for New Zealand. And I think that this starts at the top. Recently, I sit on what is called our PCIA with the South Canterbury District Health Board. And we got handed this document on healthcare homes. And fortunately, our CEO was sitting in on the meeting, and I said to them, this is not a model for general practice. Most of us do this already, but this is a model for our district health board. And he's taken that on board. So I think that, this is where it starts, but we need to expand on this quite considerably because I think it's how we get healthier communities. It's not about, top down.
Yeah. I mean, that's my passion. I think that the top-down approach never really works. There's been a litany of failed disasters in the New Zealand healthcare system with top-down approaches, and it's time that we had a grassroots revolution coming up.
Hi, Martin London. I'm a roving rural locum based in Christchurch. Fantastic talk. I won't repeat what they said. It's just wonderful. It struck me what you mentioned about patient portals and how wonderful it might be for the practice. I went to a demonstration a couple of weeks ago in Christchurch of different PMS systems, the whole, over the country, it's in upheaval at the moment. And they started to say how you could get a virtual receptionist, you get your blood pressure taken at the door by an automatic thing, you'd arrive with the doctor with all these parameters, these measurements, these measurable outcomes done. And it horrified me, the idea of that separation from the human experience of coming to meet a team and spending time, 2 human beings together. And I get progressively more scared that we're delivering completely the wrong sort of medicine that makes people feel healthier and experience healthy lives, even if they go on for a very long time into dementia. I think I'm going into dementia over the issue, and many of you will have recognized it long before I did. But have you a comment on this IT mechanization of efficient practice that's sucking the heart out of what we do with our patients?
Yeah, it depends on what you term quality healthcare. Because our funders would have us believe that quality healthcare is a low HbA1c and low blood pressure, etc. My PhD's in asking people what they think quality healthcare is. And so far, people are telling me it's about the relationship they have with their healthcare providers, and that makes the difference to them. So I agree with you totally, Martin, that we have to be really careful with how we're going. We're quantifying something which is a qualifiable measure. Right? Yep.
Hi all, Nairi Kirst. Kyle, thank you for a fantastic talk. Could you also comment on the corporatisation of general practice throughout New Zealand at the moment, and how we can maintain community connections through this corporatisation, and how we can maintain the doctor-patient relationship?
I think there probably there's an opportunity for corporates to embed communities. I mean, they can look at how they embed that in their structures. So I think there's an opportunity for corporates to become more involved with communities. Yeah. Well, thank you very much.